So now, just look at this picture and try to write the external features. So in the midline, you are finding in the medulla oblongata, there is a fissure, you call it as anterior median fissure. Then it will have decussations like this, pyramidal decussations. Do you remember like pyramidal tracts? They will cross over 70 to 90% of fibers will cross, right? So these decussations are actually called as pyramidal decussations, which we see in the lower part of the anterior median sulcus. Okay, then behind, between these two facial colliculi, and if you come down, there is one line in the midline, right? That is actually posterior median sulcus. Okay, then we have like this is anterolateral and posterolateral sulcus. This is also anterolateral and posterolateral sulcus. Okay, so then we have like pyramid is there. See, these two elevations are pyramids. Adjacent to pyramids, these two elevations are called as olives. Okay, so here lower down, I told you the connection between medulla and cerebellum. This connection, what is it? Inferior cerebellar peduncle. Okay, as you come and see down, you are finding two elevations. One is gracile tubercle, which is near to the midline, cuneate tubercle, which is away from midline. Gracile tubercle, cuneate tubercle, same name, gracile tubercle, cuneate tubercle. Okay, so you need to practice these diagrams to discuss external features. Okay, then. So internal features, I said, how many sections do we take? At midbrain, though we took only 2. Pons also, we took upper pons, lower pons. But in medulla oblongata, we take 3 sections. Okay, one section we will take close to pyramidal decussation. One section we will take little lower down, you call it as sensory decussation. And the last section we will see at the level of the upper part of the fourth ventricle. Okay, see, this is lower closed part. Okay, then this is the middle part. Okay, then you will have this area as pyramidal decussations. Okay, so that is open part. Like these are the 3 levels what we are taking. Okay, and this is first one, that is we are taking first section, this black line, that is the lower closed part, you call it as pyramidal decussation. Second is sensory decussation, and third one is actually open part, which we see in the fourth ventricle. Okay, that is. So here we have to learn 3 sections, beta. So just keep seeing that. Easily practice this diagram, beta. Most probable ones I am telling you. This is important. Pyramidal decussation is important. Then midbrain section at inferior colliculus is important. And pons usually is not asked, beta. At least these 2 sections.
Lower pons important, ma'am. Lower pons.
Okay, learn lower pons. Yes, but pyramidal decussations is very important, beta. Usual question that is. Okay.
Yes, ma'am.
So this is same thing. It is being written like what is what is what. You don't like go with these many details. You will just go mad. This is second section. This is called as sensory decussation. Above pyramidal decussation. Black line paina inko line unde kada adi. Akkada తీసుకున్నాం. That section bit. The underlying nuclei will be different. Okay, this is fasciculus, nucleus gracilis, nucleus cuneatus. Okay, this is trigeminal nerve nucleus. Okay, many cranial nerve nucleus and tracts are there. Okay, then last is up this part beta. What is called as open part of medulla oblongata. This one, third section we take here. First section pyramidal decussation. Second section sensory decussation. Third section fourth ventricle. You call it as upper open part of fourth ventricle, which is nothing but medulla oblongata. Okay, so yes, then little good picture I will give you. Okay. So you better practice from your textbook. Nice picture. Okay, so that is you have to draw like label all these 3, but all these 3 are may not be, but sensory pyramidal decussation is very, very.
They are easy, ma'am. From Vishram Singh, they are easy, ma'am. Like diagram.
Even Chaurasia is also easy, beta. Whatever you have practiced till now. ఇప్పటి వరకు ఏ బుక్ నుంచి ఆల్రెడీ లెవెల్ క్వశ్చన్. In case of lateral medullary syndrome, patient will come to us with loss of pain and temperature sensation over ipsilateral face. That means same side of the face is damaged, and contralateral half of the body. That means half of the other side of the body is damaged. Ataxia, that is loss of coordination. Vertigo is some chakkar type of sensation, reeling sensation. Then loss of gag reflex, that means swallowing reflex is not there. Difficulty in articulation of speech, person will not be able to speak. Horner syndrome generally we study under brachial plexus injuries. There will be dilatation of pupil, and there will be sympathetic tone will be gone, and there will be permanent the skin always feels hot. Okay, so because the centers are damaged in medulla oblongata, there will be vomiting, nausea, nystagmus. To and fro movements of eyeball is called as nystagmus. Hiccups may be there. Okay, then ocular lateropulation, that means eyeballs may be protruded outside. Okay, these are the clinical symptoms of lateral medullary syndrome. Lateral medullary syndrome can come either as 3 marks or 5 marks question. You should give the cause and you should give the clinical symptoms. Cause is pica, posterior inferior cerebellar artery thrombosis, and these are the clinical symptoms. Okay. Now, see here, this is lateral medullary syndrome, and this is the area which is supplied by pica, posterior inferior cerebellar artery. Okay, so all these areas we have hypoglossal nerve, we have vagus nerve. That's why gag reflex is gone. Swallowing has become difficult. Speech articulation is gone because hypoglossal tongue muscles cannot move properly. Okay, all these areas are having the underlying cranial nerves, because of which these clinical symptoms are present. Okay, then we have medial medullary syndrome, also called as Dejerene's anterior bulbar syndrome. Okay, so in case of this, what you will see, what is damaged, I said, which artery is blocked? This central artery. What do you call it as? Vertebral artery. So if this vertebral artery is damaged, you will see the paralysis of homolateral half of the tongue. That means same side of the tongue is not functioning. Then contralateral paralysis of the opposite half of the body, and loss of kinesthesia. What do you mean by that? Means movement sense is not there. If something is moving, person will not be able to appreciate. Okay, and discriminative touch is also gone. So these are the clinical symptoms of medial medullary syndrome. Okay. Okay, that's it, beta. So that is all about brainstem. Let me check what are the other questions shared by you. Meanwhile, keep studying something.
Yes,
Beta?
ma'am.
Okay.
Yes, ma'am.
So what are we finding? See, we are finding this is vertebral artery. This is also vertebral artery. Draw well labeled picture, but I will tell you everything. Right and left vertebral arteries are joining to form basilar artery. Then basilar artery, you are finding this is dividing now into posterior cerebral artery. Nicely different colors are used. Three major arteries are there in circle of Willis, Niharika. From behind, we have two posterior cerebral arteries. From middle, we have middle cerebral artery, and in anterior, we have anterior cerebral artery. Okay, so posterior, middle, and anterior cerebral. They are all connected. Okay, like posterior and middle are connected by means of posterior communicating, and two anteriors are connected by anterior communicating. Hence, it forms a circle, isn't it, Niharika?
Yes, ma'am. Yes, ma'am.
Got it?
Yes, ma'am.
So this circle is called as circle of Willis. So from this circle of Willis, you will see what are the other branches you are finding from vertebral arteries. We are finding anterior spinal artery, which goes and supplies the spinal cord. Just now we have studied pica, isn't it?
Yes, ma'am.
Posterior, yes, ma'am. Posterior inferior cerebellar
Inferior
artery.
cerebral artery.
Posterior inferior
Yes, ma'am.
cerebellar artery, isn't it? With the medulla oblongata lesions, isn't it? Weber's, like medullary syndromes, isn't it? So this posterior inferior cerebellar artery basically supplies cerebellum. Then you have, this is anterior inferior cerebellar artery. This is also supplying cerebellum. Then when we were doing pons, I said basilar artery is giving so many pontine branches. These are pontine arteries. Okay. 4 number, 4, 4, 4, or 10 also you can draw. Then you are finding this is superior cerebellar artery. That means cerebellum will be like this better. Okay. And this is completely circle of Willis, no? So in the middle of circle, you have posterior medial central arteries. Here anterior medial central arteries. Okay. There is one artery which is moving like this. You call it as recurrent artery of Hübner. Recurrent artery of Hübner. Okay. So these are the arteries which you should label and draw, and this circle of Willis we will be seeing at the base of the brain. Okay, if you just see complete brain, exactly the position of the circle of Willis is like this, Niharika. At the base of the brain, see this is medulla oblongata, this is pons, and this is midbrain, and you are finding a circle like this. Okay, so this circle is nothing but circle of Willis. Is that clear,
Yes,
better?
ma'am. Yes,
Yes,
ma'am.
Okay.
yes, ma'am.
Okay. So then,
In recent exam, they asked this, ma'am. Branches of circle of Willis. Name branches of circle. Yes, ma'am.
okay.
This
Oh,
March
actually,
exam.
no, actually, your paper was in fact. I'll try to make it fast only because it was already dealt, and Puram also basically fast only. See, under these headings, we need to generally discuss. We should know what type of joint it is, what are the bones forming, what are the ligaments we have around, bursae, relations, blood supply, nerve supply, movements, and muscles which are producing the movements and applied aspects. Okay. So under these headings, question will be usually asked. So hip joint is multi-axial ball and socket type of joint, beta. So how is it formed? Like it is formed between the head of the femur and the glenoid cavity of the acetabulum. Sorry, acetabulum of the hip bone. Okay. So now the articular surfaces, see this area is the acetabulum of the hip bone, which is like horseshoe shaped or semilunar shaped. So this particular area is covered with hyaline cartilage, also called as articular cartilage. And in between you have a fossa where we will have lot of fat. And this lower edge of this acetabulum is bridged by transverse acetabular ligament. Okay. So this is the head of the femur. The center of the head of the femur will have fovea, which gives attachment to ligament of the head of the femur. So let us see what are the various ligaments which we are supposed to know. So we should know fibrous capsule. We should know acetabular labrum, iliofemoral, ischiofemoral, pubofemoral ligaments, ligament of the head of the femur, and transverse ligament. Okay, now see here. So whatever is covering the margins of the acetabulum and along the intertrochanteric line and intertrochanteric crust of the upper end of the femur, that line, along that line you will have the capsular attachment. Okay, so that is all attachment of capsule. Ligamentum teres or ligament of the head of the femur is actually extending from the fovea, which is present at the center of the head of the femur, to transverse acetabular ligament. Okay. So inside covering of the fibrous capsule will be synovial membrane that will be filling the joint cavity with the synovial fluid, which will help in the lubrication of the bones while various movements. Okay. Then so synovial membrane is actually lining inside. Okay. Then synovial membrane, I told you it is helping in formation of synovial fluid. Then see, the margins of the acetabulum will have a fibrocartilaginous rim. That fibrocartilaginous rim is nothing but acetabular labrum. Okay, so you can see in fact, this is our acetabular cartilage, horseshoe shaped. This is pad of fat. This is ligament of the head of the femur called as ligamentum teres. This is transverse acetabular ligament. Surrounding the acetabulum, the fibrocartilage. This is the fibrocartilage, what we see, you call it as acetabular labrum. Okay, this is ligament of the head of the femur. So this is transverse acetabular ligament. This is ligament of the head of the femur. Same thing, ligament of the head of the femur is shown in different pictures. It has been cut to show how it is attached to transverse acetabular ligament. Head of the femur is also covered with hyaline cartilage, also called as articular cartilage. Then what are the other ligaments we have? The iliofemoral ligament. This is anterior inferior iliac spine of the hip bone. From there you are finding it is going to intertrochanteric line anteriorly. This is also called as ligament of Bigelow, and this is the strongest ligament of our body which helps in standing in erect position. It is inverted Y-shaped ligament. Okay, then iliofemoral ligament. So wherever we have like the extensions of synovial membrane, there we have bursa. Okay, here this bursa is filled with synovial fluid. Okay, wherever we need extra lubrication, we need this bursa. So iliofemoral ligament is extending from anterior inferior iliac spine, right? Then from the pubic bone, okay, see this is our pubic bone. This is pubic symphysis. From the pubic bone to the iliofemoral ligament itself, the fibers are moving. You call this ligament as pubofemoral ligament, extending from iliopubic eminence to the capsule of hip joint, pubofemoral ligament. Then what is the last ligament we have? Ischiofemoral ligament. See from behind, if you see, from the ischium to the tip of the greater trochanter, you are finding there is ischiofemoral ligament. Okay, ischium, ischiofemoral. Okay. So what are the various bursae? Bursae is nothing but extensions of the synovial membrane filled with synovial fluid where we need extra lubrication. So just name them. So we have iliopsoas bursa, trochanteric bursa, bursa at gluteus medius, and ischio-gluteal bursa. Okay. So this picture you have to learn. This is given in all textbooks. This picture will help us to learn the relations. Now this area is acetabulum. This light green color is acetabular labrum. Surrounding this dotted green line with gaps is fibrous capsule. Here this is the pad of fat. This is transverse acetabular ligament. This is ligament of the head of the femur, and you have all muscles: gluteus maximus, medius, minimus, tensor fasciae lata. The above muscles are superior, below muscles are inferior, near to midline are medial, away from midline are lateral. Okay, like that you will have front, behind, above, below. Table will be given in the textbook. Learn from that. Okay. Then you have blood supply. What are the nearby arteries? Femoral arteries. Branches will come and supply here. We have medial circumflex femoral, lateral circumflex femoral, obturator, superior gluteal, and inferior gluteal arteries. Okay. Nerves. Which nerves? Front of the thigh, femoral nerve. Medial compartment, obturator nerve. Isn't it? And then behind we have sciatic nerve. Okay. Then these movements also are given in the textbook table, like flexion. These are the muscles which help: iliopsoas, lateral part of pectineus, extension, gluteus maximus, hamstrings, adduction, adductors, and abduction, gluteus medius, minimus, medial rotation, gluteus medius and minimus, lateral rotation, gluteus maximus. Okay. So those names you try to learn. Then you just see what are the clinical aspects. So applied anatomy, head of the femur shift upwards, that is dislocation of the head of the femur, okay, which will lead to change in the manner of walking, that is called as lurching gait, and the Trendelenburg sign is actually positive. Okay. Then if there is any degeneration of the femoral head due to non-availability of blood supply, head is getting flattened. That condition is called as Perthes disease, avascular necrosis of femoral head. Okay. Congenital dislocation of hip. That means by birth itself you will see the head of the femur may be dislocated from the acetabular cavity. Okay. The best position how the baby has to be carried is in this way, which will bring the head of the femur back into the acetabulum. Okay. So usually in the road traffic accidents only we will find there may be either dislocation or fractures. So that's all about this joint button. Others are very high level details, not required. Then femoral artery, right? Femoral artery is a branch of which artery? Rohita, you told previously. Today you are not.
External iliac.
External iliac artery.
Very good. External iliac artery. Okay. Just checking the PowerPoint better. Please wait. Meanwhile, we'll discuss. Okay. What are the branches of femoral artery we have? Do you remember? Anybody remembers? 3 superficial and 3 deep branches. Superficial circumflex iliac, superficial epigastric, superficial external pudendal. Isn't it? Then deep branches are deep external pudendal, profunda femoris, muscular branches. Again from profunda femoris we have medial circumflex femoral, lateral circumflex femoral. We have perforating branches which go behind, piercing through the openings of adductor magnus. They form certain anastomosis like trochanteric anastomosis, cruciate anastomosis. Then femoral artery finally pierces the big opening of adductor magnus, which is called as hiatus. Hiatus, isn't it? From where you will see it will be entering into the popliteal fossa. Thereby it continues as popliteal artery. So in the popliteal fossa, popliteal artery is related to popliteal vein and the sciatic nerve terminal branches. What are those? Tibial and common peroneal nerve. What are the branches of popliteal artery? All genicular branches it gives. Superior medial genicular, superior lateral genicular, inferior medial genicular, inferior lateral genicular, middle genicular. Okay, better I take the help of internet only. For the moment, I am not finding PowerPoint. First, I will give you a very simple picture. Then I will take you to little branches type of picture, which initially I don't want to trouble you with complicated image. See, first thing I am showing you a very simple picture of the femoral artery. So we know like this is the front of the thigh. In the front of the thigh, we know this is the inguinal ligament, isn't it? So here you are finding below the inguinal ligament